All right. Well, we might get going and see how we go with people. So, hello everybody. I'm John Beard. I work with the University of New South Wales in Australia, although I'm based here in Geneva. And previously, for 10 years, I was the Director of Aging and Life course with the World Health Organization here in Geneva. The way this session works is I'm going to do a brief presentation of maybe 5 or 7 minutes, and then we can go anywhere where you want, and I can answer any questions, whether they be on some of the things I talk about, whether there are other issues relating to healthy longevity, or whether it might be just you want to talk about how you might get to work for WHO, for example. So I will now open a presentation and get going. Get the whole thing up. Sorry, I've got a screen in front of me from. All right. So what I'm going to do for this talk is focus on the 10 years during which I worked at WHO. And it was an interesting period. The first 5 years of that time, I'd have to say, I experienced extensive ageism in terms of the buy-in of potential stakeholders and the idea that really aging was marginalized in the main work of WHO, and it was very hard to get on government's agendas. We also were working during a period when the dominant discourse about aging had shifted from older people being frail and necessarily withdrawn to one where it was considered they were more active. But I'd have to say that there was also underlying that discourse, there's always been this idea that they're a financial burden on society, and the model shifted from they were a financial burden because they were frail to what may even have been worse, they were a financial burden because they were lazy and they should be in the workforce. And up until, well, when I started at WHO, the dominant framework for the policy we had in engaging with governments was active aging, and that was interpreted particularly by countries in the European Union as basically focusing on getting as many older people as possible in the workforce. It wasn't focused on trying to build the strengths and capabilities of older people. So we wanted to shift all of that, and we thought through a process of how we might do that globally. And the first was to try to reconceptualize the problem and the potential solutions. And to do that, we spent a number of years developing what's called the World Report on Aging and Health, and you can access that on the web. It's very heavily referenced, and it's been downloaded over 1 million times. So it's been very influential. And I'll talk about that, what that reconceptualization entailed in a moment. We then looked at, having reframed the issue, how can we get the political mandate for action? And we worked with a number of countries around the world to develop what was adopted by WHO as the Global Strategy and Action Plan on Aging and Health, and has now been adopted by the United Nations as the Decade of Healthy Aging, which will run from 2020 to 2030, and through which time we would hope we actually see some action. So to just talk a little bit about how we reconceptualize the issue of aging, we tried to basically build on the constitution of WHO, which says that health is more than the absence of disease. But I'd have to say that in the 70 years or so since that constitution was endorsed by countries around the world, WHO really hasn't acted very much on it. So we had to start from scratch and frame what that might mean. And in the World Report, we decided to focus on healthy aging, which you can think of the same as healthy longevity. I think it's the same sort of thinking. But rather than focusing on healthy aging being the absence of disease, we focused on it as being the process of developing and maintaining the functional ability that enables people to be and to do the things they value in older age, and thereby achieve well-being. And this is a capabilities model which was developed initially by Amartya Sen. He won the Nobel Prize for it. So we adopted it for the idea of aging and healthy aging. Now, if you think about what is the functional ability that enables well-being in older age, there are a number of different components. In 2015, we came up with what I'm about to show you, but it's been developed a little bit since then. But I think this captures the key ideas. So every older people, to achieve well-being, needs their basic needs met. They need to have housing, they need to have safety, financial security, access to healthy food, and so on. Most older people want to retain autonomy in their lives as they grow older, and they want to continue to learn and to grow. I hope I'll be doing that until my last breath. Mobility is very important for older people to get where they need to be to do the things they value. And relationships are absolutely critically important. And finally, older people, and I think I would change this from this figure, which comes from 2015, from just being, they don't just want to contribute, but they want to be acknowledged and valued as people. They want to participate and engage. So these are the sorts of things that older people want if they're going to experience well-being. Part of whether they achieve it or not will be determined by the individual, and part of it will be determined by the environment that they live in. So, for example, for me to read your names on the screen here, I need an environmental aid to be able to do that. So my vision is okay, but the environmental aid allows me to do what I want to do. Now, if we look at the individual for a while, and I'm having to squeeze this down into incredibly tight time frame, so I'm not going to really get a chance to talk about those environmental characteristics. But if we think about the individual, one of the problems we faced when we started to get people to reframe what aging entailed was this idea that there's a typical older person, and that some day or some night at midnight, based on your chronological age, you suddenly become old, and everybody above that age is the same. And what this figure shows is those individual level characteristics of the person that contribute to their ability. We call this intrinsic capacity. What it shows is a schematic of the range of intrinsic capacity with increasing age. We haven't got a number down the bottom because it's just to show you the idea. And what happens is, as you get older, the range of intrinsic capacity increases. Diversity increases. And so saying that anybody in this square, 65 and above, is typical is impossible, because there is an incredible range of experience and health state. In what we tried to do at WHO was to use that as the starting point for framing some political action, and we identified 3 separate periods within that second half of life, where people might be having quite distinct experiences, and where the policies and the interventions that they might require might be different. So we talked about a period of high and stable capacity, a period of declining capacity, and a period of significant losses. And for each of these groups, they have quite different requirements. So for people with high and stable capacity, often the environment presents barriers to their engaging. So ageism and age discrimination, like mandatory retirement age. For these people, what we need to be doing is breaking down those barriers and trying to enable them to retain those high levels through screening for disease and through appropriate behavioral interventions. But a significant proportion of people in the second half of life actually are experiencing declining capacity, often from complex chronic morbidities. And for this group, we actually need to completely reframe the health system away from the sort of acute care that it currently delivers to being able to provide holistic chronic care that's integrated and framed around the holistic needs of the older person themselves. This is also a period where the environment can help you adapt to those losses or compensate for them. And so at WHO, we created the Global Network of Age-Friendly Cities to try and create more supportive environments to help people do that. And then there's a group in the second half of life who have experienced already significant losses of capacity, and these are people who require long-term care. And we need to be putting in place long-term, or ensuring access to long-term care in all its forms for people who have experienced these losses in all parts of the world. And that's a major challenge. Now, if you think back to that box of everybody over the age of 65, you can see that that group can include people in any of these different subgroups. And so we need, instead of having some sort of generic stereotyped policy and response, we need to be thinking about a comprehensive, complex response which deals with this complexity. To give you an idea of the work I've been doing since leaving WHO, what we've been trying to do is think about this idea of intrinsic capacity and how you might measure it. And this is a figure from a couple of papers, one that's just come out in journals of gerontology, medical science, and another from the BMJ Open, where we followed large cohorts in England and in China and tried to think about what would this thing, intrinsic capacity, all the individual level attributes that contribute to your ability to be and do the things you value. How might you frame it? How might you think about it? How might you measure it away from the idea of disease? And we came up with this figure, which shows at the top a range of critical expressed capacities: your locomotor capacity, your cognitive capacity, your sensory capacity, and so on. But underneath all of that is another capacity, which is the capacity to retain the level that you are currently experiencing in those expressed capacities. And this is where the whole field of geroscience, where I think a lot of the work that is being discussed in this meeting actually ties in. And if you look at this, it actually gives you a very different way about thinking about geroscience and some of those initiatives in that area, away from the idea that we measure success in interventions, whether it be in terms of cellular senescence or epigenetic change and so on. Instead of looking at the impact they have on the presence or absence of subsequent disease, looking at the impact they have on functioning. And this is just a figure just to show that if you actually look in those longitudinal studies, it is quite clear that this measure of intrinsic capacity, these functional attributes, are very predictive of outcome and quite independently of the number of morbidities that somebody's experiencing and independently of a range of personal characteristics. So this is information which we're currently not really collecting, not following, and which would be very useful in terms of determining the outcomes that people have. It's also something we could be measuring across the whole of the second half of life, not waiting till people are 60, 70, 80, but starting in their 30s and 40s. So that's just a quick introduction. These were a couple of possible discussion points I thought you might find interesting. What we tried to do at WHO was change the world, and might have only been this much, but I think we were successful. You might want to talk about how we can change the world based on whatever it is you're interested in. You might also want to talk about your careers, how you get, or if you would like to work for an organization like WHO. Or you might want to talk about what I was speaking about at the end. How can you think about health beyond the absence of disease, and how can you do that? And when you're thinking about technology, geroscience, and functioning. So I will turn that off, and let's keep this open and informal. And I'm not sure how we manage the your questions, but please feel free to ask whatever you want. Okay, so we've got a question. Hugh.
Hi, John. Thanks for talking to us today. So I'll introduce myself first. So I'm Hugh Daisy at UK Research and Innovation even. So essentially I look after the UK catalysts in the funding body environment. So for those of you who don't know, and no assumption that you should, UK Research and Innovation look after the public funding of research in the UK. So over the whole organisation, we give out about £8 billion a year. We don't have that for the catalyst, but we also have something called the Healthy Aging Challenge, which is a £98 million investment, which we run the catalyst through. So my question for John is rather a selfish one, really, but your position in the World Health Organization would have put you in this area a lot. So it'd be really fascinating to hear your reflections on much of what you're saying suggests, we need this really wide-scale systemic change. And I'm quite intrigued about what you see the greatest opportunities in that area are, and also what the significant barriers are.
Okay, well, I'll perhaps start with the Decade of Healthy Aging, which has just been endorsed by the UN, and the 4 strategies which it's identified as critical for moving forward. And the first one is to change the way we think, feel, and act about aging and older people, to combat ageism, basically. And I think it's absolutely critical, and you can't even start to deal with the other ones until you start to address ageism. And these assumptions, which I was trying to capture at the beginning, of there potentially being a typical older person, that everybody is the same and there's a generic response to the needs, or your needs, as your chronological age increases. So there's an awful lot of work to do there, but unless we do that, then the questions which people pose and the solutions they consider are really, they're only going to hit whatever their target is. They're not going to be thinking about how they can their interventions, for example, might be much more personalized. You might develop a technology that relates to this person here, but it's missing out on all these others. But by some sort of modification, you could make it much more flexible and accessible. So number one is combating ageism. Number two, and I didn't really sort of focus on it, but is looking at the environments that we live in and trying to create more supportive environments. And they can be supportive in 2 ways. One is they can help the individual to build and maintain their capacity. So, if you live in a safe environment where you see lots of other people your age out on the street, you're much more likely to get out, be active, and to maintain health in that way. Similarly, if people are all eating healthy food, you're more likely to eat healthy food. So focusing on the environment, and that's physical and social, and how we can allow it to help people build and maintain capacity, but also, as I mentioned before, how we can design environments that allow people to adapt to or compensate for losses. And so, a very simple example would be if you have severe hip arthritis, if you can have disabled access public transport, you can still get where you need to go. And so the environment can help you compensate for those problems. The third and fourth are aligned to the services which we provide. And the first one is health services. And there we need to shift from health services which are designed to react to individual conditions and cure them, to health services which look at the whole person, try and prioritize then the interventions that they need, and to then provide what's normally chronic ongoing care in a way that actually fits in with the aspirations of that person and with their trajectory of capacity. And then the final one, and this is one of the, and I mean, that's incredibly challenging. And the reason that's the health system is incredibly challenging is because you've got vested institutionalized interests, and so you have to combat them. And then the final one is how do we build systems of long-term care? How do we provide the social care and support that older people require? And how do we enable equitable access to it? And that could be support and care in people's homes, or it could be going through to institutionalized care. And I think here, this is an area where technology is going to be incredibly important in all of those settings. And then underpinning those 4 main streams, I do think there is this whole development in the field of geroscience and thinking about the complex physiologic dynamics which underpin all the changes we see in older age, and how we can consider them so that we can foster intrinsic capacity as long as possible. And also technology. For all of those things, technology is going to be incredibly important, but it needs to move beyond the technology, which is the tail wagging the dog, where some designer comes up with something and then they try and fit it to their stereotype of aging, instead trying to really co-design with older people to identify what their needs are and what some innovative solutions might be. So if I was you, I would fund all of those sorts of things as well as more. Does that answer your question?
Yeah, that's brilliant. And it's good to see that what you're saying kind of reflects what we've been approaching in the challenge as well. Obviously, we never have enough money to do all the things that need doing here, but it's a good starting point. Thanks.
I think that the other thing I didn't mention, which is critically important, is equity and how you can ensure all of those things, and all of those things don't just go to well-off people like me, but actually are accessible and affordable for everybody. And in fact, that we prioritize people at the bottom. So it's not just a question of shifting everybody up, it's a question of paying particular attention to those at the bottom, so that diversity we spoke about is reduced, because that range of capacity that I showed in that figure is not by chance. The people in older age who have the highest capacity are those who generally experience the cumulative impact of advantage across their lives. Those at the bottom have generally experienced the cumulative impact of disadvantage, and that means that they then have the least access to the resources they need to meet the reduced capacity, which is the consequence of that disadvantage. So trying to think about how we can overcome those ingrained trends is really important, and that's both within countries. So in the UK, you might think of poor and rich parts of the country, or poor and rich people, but it's also between countries. And for me, you know, there's a passion to ensure that people in every country can have the benefit of this stuff we're talking about.
Yeah, thank you. The equity thing is particularly interesting. I mean, one of the aspects we have on the challenge, one of our stated aims, is to reduce the gap between the richest and poorest. And some of the recent data in the UK is suggesting that is actually going backwards, or that gap is growing for the first time in many years, which is obviously quite a concern.
I'll go on to some others in a second, but quickly, there was some interesting research in the UK. I think Michael Marmot did it, where they looked at local government areas, and what they found was, if you lived in the poorest local government areas, your health status was much lower than in others. That's been found in a lot of research, but they found that the impact of increasing retirement age actually increased that disparity, because in poor areas, almost everybody below the current retirement age is already experiencing some form of disability, whereas in the wealthier areas they're not. So increasing the retirement age didn't have much impact on people like me, but it reinforced the inequities which were already present. So it's really interesting to think about policy and how it might inadvertently impact on people in inequitable ways. So other questions, and it could be on absolutely anything that you want. And if you can either speak out or you can raise your hand.
Okay, so thank you, John. I am a biomedical scientist working in Colombia in South America, but I am also very interested in the field of education. That is sort of my passion. And I became involved in health literacy research during the last couple of years. So we are planning to monitor or to evaluate the level of health literacy in patients in Colombia, and focusing on aging populations, because my focus is cardiovascular disease. So what do you think that we should be working on this field? Because I feel that it could be a cost-effective solution for some issues, not all of them, but being a pharmacologist by training, I also recognize that, for example, a lot of the aged people, they are polymedicated. They are receiving multiple medications to treat chronic conditions. They are at high risk of different complications. But normally, these populations are their caretakers, have low literacy levels, that makes them more susceptible to these secondary adverse outcomes. So what do you think that we should be doing to address these issues?
Okay, I think it's an incredibly important area, and I can see, I mean, I'm just thinking off the top of my head here, but I can see three particular areas to focus on. One is trying to enable everybody to understand the process of aging and what it commonly entails, what's normal, what's not normal, and how the aging process may require the seeking of different forms of healthcare or particularly and social care. So that would be number one. Number two is, I think the issue around caregivers is really, really important. Caregiving can be a very rewarding experience, but it can also be a significant burden. And often the thing that defines being in one group or the other is your understanding and knowledge of what's going on. And so particularly with issues like dementia, caregivers are often grappling with things that are totally bizarre, and they really cannot understand what's happening. It's incredibly stressful. And so providing them with basic information on the process of dementia, which I'll use as an example, and then providing some simple solutions to common issues that arise. That sort of, I think, health literacy is really, really important for caregivers themselves. And then the final one is how to navigate through the system. And it's more than health literacy, because the systems need changing to make sure that they're more navigable. But for people with complex conditions, they often, and I'm thinking in a poorer country, they may finally see somebody who'll deal with the condition that they present with, and then they've got other conditions and that person is not going to respond to, and they may end up seeing several people, and like you say, they end up on polypharmacy. The clinicians may not consider the potential side effects or the cumulative impact of the different medications. So I think, almost, and in a sense, it is health literacy, but I think there's also a need for perhaps some technological help in terms of navigating the system, aligned to being aware of what your needs actually are, and also what your rights are. That would be another one, I think, is the issue of autonomy and what is reasonable for an older person to expect. What rights do I have to say no? What rights do I have to demand something else? So I think, thinking about all of those things to me would be important. Had you any ideas of your own?
No, so right now we are trying to do some of the steps that you mentioned. So we are preparing a couple of courses, like massive online open courses, but not like the traditional ones found in Coursera or EDX, but some that are posted in some of our platforms in the health secretary in our city, and that are adapted to the health literacy level of the people in our population. And we are trying to provide basic content supported by gamification to make the people feel more engaged with the educational activities, because we consider that is important. Otherwise, we are delivering information, but the information is not necessarily inducing a change in behavior.
Yeah.
And what we are trying to do is to address, to open spaces to listen to the needs of both the patients and the caregivers, because a lot of times we feel that there are some, how can I say that, like simple issues that can be solved just listening to them and trying to solve the particular problems that they are presenting.
Cool. Well, a resource you might find useful if you go to the WHO website is the Integrated Care for Older People program. And it's a program which is trying to use a functional approach to developing services. So rather than diagnosing a disease, it looks at somebody's functional state in those areas of, I spoke about locomotor capacity, cognitive capacity, and so on. And then it creates care pathways. And those care pathways actually go through to the provision of social care. So it might be, a useful tool, and it's available as an app, and anybody can use it. So it may complicate things for you, but you might also find it a useful resource. So it's the Integrated Care for Older People. If you just enter that and WHO, you'll navigate there.
Yeah, I just found it. So thank you very much. My wife is an ENT surgeon, and normally most of ENTs, for example, are very interested in these complicated surgeries for deafness in relatively young people, but she's very interested also in geriatric otolaryngology. So these kind of resources are very useful because a lot of times I think that the health system don't see them as profitable. I don't like to use that term, but profitable customers, and sometimes they are not provided with the best quality of care. So I appreciate your suggestion. Thank you.
Well, you will see in the iCope tool that there's a special thread for hearing. And it starts with a very basic whisper test and then progresses through. So she might like it. Other questions? You must have something.
Hi, John. I'm Will Tope. I'm the Associate Professor of Psychology at Singapore Management University. And listening to talk about age-friendly cities, when I hear that term, I think about, trying to make it easier for older adults who, they're experiencing physical disabilities. But, another issue that is important in aging is this issue of loneliness. And so I was wondering, if you're familiar with any approaches or interventions, especially in terms of environment, facilitating social interactions among older adults.
Yeah, look, it's a critical area, and actually, there's some great work happening in Singapore. There's a community intervention there that I'm engaged with. But there's a lot of work happening in different places. With the Global Network of Age-Friendly Cities, it's also an issue that they've looked at, because it's not just about providing physical environments, it's about how do you create more supportive social environments. And a key issue there is connectivity, like how do you bring people together, how do you keep them engaged? And there's if you look at people who have severe losses of capacity, in the olden days in Europe, they used to be put in a horrible institution and basically left there to die. It was like God's waiting room. What happened afterwards is people they tried to shift them back into the community, but a lot of those people were actually worse off because they're then sitting in their homes without anybody visiting, totally isolated. And even if they have somebody come every 3 days, it might be the only person they speak to. So and as I tried to show in that figure at the beginning, relationships actually become more important as you age. Older people report a greater importance of relationships. So in terms of trying to steer you to the best, I can't do it. It's not my sort of area of expertise, but I completely buy in that it's a really important area. There are a lot of sort of community initiatives. There are people there was one, and I'm trying to remember where it was, where they engaged the postman to say hello, even if he didn't have a letter, and to check in periodically, even if it's only every couple of weeks. And in some, I think that was in rural France, and in some of those places, again, that might be the only personal contact that person has. But so there are a number of initiatives around, but I can't steer you to the best, I'm afraid. Other questions?
It's totally fine.
Okay.
Yeah.
Okay, so if you don't ask a question, I'm going to call on you. Hillary, are you still there, or have you got anything to ask? You're on mute. You're on mute.
Hi, thank you so much for such an informative, interesting presentation. One of the things I found very interesting, I work with a foundation and we specialize in promoting awareness of how medical grade oxygen under pressure can help brain health. So one of the things, and it's an innovative idea and area of something that's been around for a long time, and it's evidence-based, and it's being used in many hospitals in our country to help with wound care, but this is a different kind of a wound. wound in the brain, which also the state of your brain obviously contributes to healthy aging. So it's so many interesting correlations. And we work with, helping young people, concussed student athletes, and equestrians and veterans, and seeing their brains recover through the use of this applied medical grade oxygen under pressure is very exciting. And I always think that it's giving them such a better future. So I found it very interesting that you mentioned that WHO was originally founded, it's such a well-respected, well-established organization that it was originally founded to change the world. And I think that's, very exciting. And do you have ideas, and you've mentioned too that it takes a long time in an organization as large as that to make things happen, new things. And I know one of the barriers might be you mentioned special interests in healthcare. Do you have any ideas for dealing with that, for helping healthcare organizations overcome possibly their special interest to work together? As we all know, we're stronger working together. Do you have any ideas about that?
Okay, well, a couple of things. First of all, I think it's great you're looking at cognitive function as an outcome in terms of the impact of the intervention. And what you could also think of, and you mentioned athletes, which is where I'm aware of oxygen being sort of used to help recovery and so on. You could actually broaden the outcome to thinking of other components of capacity, like locomotor capacity. So in terms of outcomes, I would look at a whole range of different things, and it's quite possible that the intervention could, and I'm not saying it does, but it's quite possible it may also have positive impacts on declines in locomotor capacity, or maybe even in helping people recover from frailty. So, I mean, I would be thinking more broadly than just the cognitive function. In terms of how you change the world, vested interests. Yeah, I've got a lot of experience in this, normally from the other side, where when I was at WHO, people would come to me with what they thought was this terrific idea, but it was their idea and there wasn't big buy-in to it. And I could tell you right from the very beginning that you weren't going to get major global buy-in by governments, because they would just think that it's you pushing your own vested interests. So I think there's two ways you can try to overcome that. One is to strengthen the evidence, and the more evidence you've got, the better, and the broader the population you're working on, the better. And if you've got some form of economic analysis of the costs and the potential benefits, it really helps. When I started working in the area of aging 20 years or so ago, I worked on a falls prevention program, which at that time was really not sexy, but we managed to do a very comprehensive intervention and demonstrated that a community-based program could reduce hospital admissions, and it was in a very cost-effective way. Every dollar spent saved 20. So then in Australia, where I was working at the time, it suddenly falls became sexy and taken up by a lot of governments. So if you can get some sort of economic analysis, it would help. And then the other is, I often encourage, so I'm working with some people at the moment who are interested in osteoporosis. And what I tell them is, okay, you might get somewhere with osteoporosis. It's an important issue. There's strong economic arguments for some sort of intervention. But I think you're much more likely to get real buy-in if you're working on bone health. So if you're thinking more broadly, rather than just that component of bone health, and trying to pull something together in a more comprehensive way that governments can get their teeth into. So either demonstrate a fantastic cost-benefit ratio, or somehow link in with other people working on cognitive function, or like I say, thinking about other outcomes like frailty and locomotor capacity areas I would suggest. And the other thing is, you can have big aspirations, but you have to understand that you might only move the world that much, but you're moving the whole world. You know, that's so, you know, you might not get everything you want, but if once you become global, the impact can be incredible. Okay, we're going to run out of time soon, but I'm going to keep going around while I can. Catherine, I see you've just turned your camera on. Ask me a question.
Hi, good evening, sir.
Hi. Where are you?
Sir, I'm in Philippines, sir.
Okay.
Yes, sir. I'm still thinking about what question I'll be asking.
I'm not going to embarrass you. I mean, you know, WHO has an office in the Philippines in Manila. I've been to there many times. I mean, okay, let me see. I mean, here's a question I thought might have come up, which is, you know, how do I get to work for WHO? What did you do to get there? And I can't give you an answer. It's my own career is incredibly unique. My PhD, I'm a doctor, a medical doctor. I did a PhD in pesticide exposure. I was the director of public health for the Olympic Games. I worked in rural health in Australia, and then I started to work on aging in New York, and I somehow ended up at WHO. So there's no sort of clear path to get into an organization like WHO. But for someone like you, who's in a low and middle income country, which is the real focus of WHO's work these days, there are opportunities, you know, through your regional office. And, you know, it might be worth sounding people out there and seeing where they might be, because on the one hand, it's incredibly rewarding for WHO. On the other, it can be very frustrating. It's like the organization gives you this incredible opportunity to make the world a better place, and then it ties your arms and your feet behind you and basically puts barriers in front of you every step of the way. But it might still be fun, and if you're in the Philippines, then I would reach out to the local regional office and see what's going on there. I don't know if you've ever been there.
Right now, sir, we are still struggling, and we hope that we have more telehealth services soon here in the Philippines.
Oh, that would be good. That would be a great start.
Can I ask one quick question, John, if Catherine is finished? Very interesting. So you mentioned strengthening the evidence. And, you know, there is already quite a bit of evidence, but strengthening the evidence does cost quite a bit of money. Do you have any, you know, it's wonderful that NAM is offering the Catalyst Awards, and that's why we applied. But do you have any other ideas for attracting funds for research in this area to help strengthen the evidence, as it is very cost-effective form of treatment and prevention?
I mean, it's really hard. It's better than it was 10 years ago, where this issue was completely ignored. But you still confront, for example, in the United States, a funding system that's really designed by disease silos, and so it's hard to tackle an issue like aging, and there's not much work in the National Institute of Aging in the US. Maybe London is a wonderful example of there being some funding available, but generally there's not. I think, and certainly groups like WHO, we were beggars, not funders. It was almost impossible for me to get funding for everything that I described. When I started there, my department was me and a administrative assistant, and it was very hard to get buy-in. I mean, fortunately, the field has become a bit sexier, and there's more and more interest. I think what you have to do is think really strategically. What I tried to show you with that time I had at WHO was how strategic we tried to be. We knew we couldn't get what we wanted unless we changed the way people thought. And so we did that, and then we tried to get the political buy-in, and now we're trying to get funding for action and so on. I think for an individual project or an individual researcher, it's get that initial data, so that it's interesting for people. And it sounds like you're starting to do that. And then you just have to do the rounds, you know, and you know, sometimes luck happens and sometimes it doesn't. I know when before I went to WHO, I worked in New York, and trying to get research funding is a hard haul. So I can just wish you luck. But so the other thing is maybe thinking you can try it in two ways. One is keeping it really narrow and the focus on cognitive function, or you might even think in people with dementia or something like that, and then you've got people who may fund that stream, or try to keep it more broad, that you've got this intervention which might impact on different aspects, and then looking for funding for those different aspects.
Yeah, good point. Yeah, thank you. It's helpful.
I think we're Jenny, when do we finish?
We are at time, which I need to unfortunately close this room so we can move to the next breakout session. But thank you everybody for participating and for the wonderful discussion. This was really fantastic.
Okay, thanks for joining me.
Thank you.
Maybe we'll see you later.
Thank you, John. Thank you, everyone.
Thanks so much.